Discounting time horizon. The issue here is, should we use a different discount rate for immunization programs? And the argument here is it might even be the case through, say, vaccination or something like that, that you eliminate a condition. And so the benefits stretch, as it were, forever. Now, we've effectively eliminated smallpox. Well, it's a bit terrifying thinking Putin's no doubt got some access to smallpox. And, well, not just Trump. I think there's about 5 centres in the world have somewhere the virus still exists. But, you know, in principle, we can. Polio, we've been quite close to eradicating, but is it Nigeria and Pakistan, I think, provide challenges, particularly. Pakistan, particularly, in terms of getting to eradication. Well, if you had a program, you might generate a benefit that lasts forever because you've eradicated a disease. Now, if you discount at any positive rate, these benefits that stretch away into the future actually start to look not very important, because the effect of discounting is to attach very low values to future events if they're far enough away. So I think there is an issue around discounting time horizon. When we think of most cases of giving people a drug treatment or whatever, the benefits stretch at most, even for a young child, stretch sort of 80, 90 years into the future. If we're thinking of some sort of intervention which might eradicate a disease, we're talking about benefits stretching hundreds, thousands of years into the future. And so the issue of what discount rate to use is quite an important topic. Non-linearities. Well, the way we purchase vaccines, at least in England, does suggest there's a non-linearity, in that if you have a very large vaccination program, you can usually negotiate a lower price per vaccine. This is much less obvious when we look at new drugs for some other condition. Quantity discounts are less obvious. So there might be some factor there that makes it look a little bit different. One interesting argument, and this is one we did accept, is that if you have the vaccine program, you perhaps avoid an epidemic. And if there was an epidemic, the consequences for the NHS, the health service, and other treatments can be very important. It can be very disruptive for the health service. And this is a phenomenon we don't get with other interventions. If there's a new drug for prostate cancer, if we don't give the new drug, if we say no to it, that's not going to, as it were, cause an epidemic of prostate cancer. Possibly, however, in some immunization programs, you risk an epidemic if you don't have the program. And the epidemic then imposes costs on the health service by displacing other NHS treatments. So that was an argument we did see merited. Uncertainty in decision making. I'm conscious of the time, and I'm almost finished. With respect to vaccines, we've got a very interesting system in England, or actually it's UK-wide for this, and that is we apply a test. We use a £20,000 threshold. Is £20,000 per QALY gained? Does the intervention meet the £20,000 threshold? Does it generate additional QALYs at a cost of up to, but not more than, 20,000? If it passes that, there's then an uncertainty test. And what's asked is, what's the likelihood that the cost per QALY, our best estimate was less than 20, what's the likelihood that it could have a cost per QALY above 30,000? And if the chance is more than 10%, we would reject the intervention. Now, this is the only instance I know anywhere in the world where there's a formal rule about how to treat uncertainty. We don't use it elsewhere in the healthcare system in the UK. What it's trying to do is avoid a situation where, although something looks cost effective, there's a substantial chance it might actually have much, much higher cost per unit of benefit. And the final issue, this is a very political one at the time and continues to be so, what should the cost effectiveness threshold be? Well, we said currently the cost effectiveness threshold is £20,000 to £30,000. This is following NICE. But there is quite a lot of evidence that the NHS can turn money into QALYs, turn money into health at a much lower rate. And the best estimate we've got is about £13,000. £13,000 per QALY. That appears to be achievable in the NHS. Now, the significance of this is if you're accepting new programs or new therapies up to £30,000 per QALY, and then you're displacing NHS activity, which could have bought QALYs for 13,000, you're going to make the NHS worse off. You're going to reduce health benefit. And the final example is a very simple calculation. Let's suppose the true cost per QALY is £20,000. We think the evidence says it's lower than that, but let's suppose it's 20,000. If you say yes to ISAs of 30,000, which is the practice at NICE, for every 10 million pounds of additional cost, you're going to have a net loss of health. And the net loss of health is 166 QALYs. So you're going to systematically make the NHS worse off in terms of the health it produces. And this is because you're using the wrong threshold. So this working group said, look, for threshold, we really should be much more realistic and use a threshold in line with the evidence. Not a popular view with the pharmaceutical industry. Anyway, so in conclusion, we decided, at least with respect to vaccination programs, there wasn't enough convincing arguments that we should use a different approach from the one we use when we evaluate pharmaceuticals. There are some differences with vaccination, immunization, but not enough to say we should be using a different set of methods. Now, maybe vaccination programs are relatively simple compared to the typical public health intervention. And so I don't want to say that what I've just said is convincing argument for using the standard economic method, but that's where we are just now. We recognize that public health interventions are more challenging to evaluate, but we think we can use our existing methods. And that's, sorry, I've overrun again. We stop there and we resume at 1 o'clock, definitely 1. And then we finish on time this afternoon.